Great, Duncan, nice to see you. So tell us a little bit about the research that you're doing for your PhD.
So the question I'm looking at is what use we, being the NHS, make of all the quality data that is available to us. Partly because it feels like we spend a lot of time and effort and energy collecting lots of data, and we want to improve, but I'm not sure that we're actually using this data for improvement. Maybe we are, and I'm not sure about it, but that's the question I want to ask. The methods I'm going to use are a mixture of methods, partly some quantitative measures with a national survey, and partly a social science type approach where I'm going to go and talk to people and ask how they feel as individual staff members or as teams in how comfortable they feel with the data they have, their skills to use it, and whether it gets used in their hospital.
Okay.
So that's new to me, and it's going to be an exciting bit of research.
Brilliant. So, so that part of the research, so the sort of term that's sometimes used to describe the sorts of methods that you're using is ethnography.
Yeah.
Tell me a bit, because that will be not have that much meaning to most doctors.
Yeah, so it's relatively new to me, but I think it comes from the Greek ethnographos. So graphos is to write, ethno is a group of people. So it's writing about a group of people or a culture. So identifying and defining culture is quite a difficult thing. And I guess what I'm looking for is how much data, quality data, is part of the everyday culture of the NHS, and particularly within perioperative services at the moment. The way I'm going to do that is with some help from experienced social scientists who are mainly anthropologists, is to go and interview people and sit down like this and ask them what they feel about what they do, but also to go and sit in on meetings and perhaps hang around with a clipboard a little bit in a coffee room and not see any patients, but to look at and listen to how they are using the data in their day-to-day life, which is really an in vivo type approach, and see how these cultures, i.e. the staff, are using the data.
Okay, so the study of cultures sounds a bit like the sort of thing that you would generally see, talked about, studying African tribes or something like that. Is this a common way of trying to understand healthcare and health?
It's an increasingly common approach, but it's quite different to traditional styles of research, particularly in anaesthetics and perioperative medicine has been used to. We're used to hard, objective, unbiased, randomised, controlled trials, giving us what we think is objective evidence as to what we use. And I don't deny that they are valuable and necessary approaches. But it seems to me like a lot of that evidence ends up sitting a bit on a bookshelf and doesn't get used day to day because of the real pragmatic challenges in hospitals, such as time pressures, chaotic infrastructure, competing priorities from national or local levels, all the things which I think we recognise in our day-to-day life as to why something might be useful. Well, we might know that a study has just come out recommending strategy A rather than strategy B, but in our hospital only strategy B works because that's the best in our hands. So I think it's that translation element which often falls down.
Yeah.
So I see them as complementary research approaches to say how are the teams and the individual working and what is enabling them, or what are the barriers to them doing what they would like to do with the objective research evidence.
Okay, so that all sounds really plausible to me. I mean, I suppose it's one of those things that is almost like taking a scientific approach to the sorts of things that we discuss in the coffee room, the things that challenge us on a day-to-day basis, the reason why sometimes it's quite hard to implement the evidence in practice.
It's exactly right. And but it's quite challenging to gather that coffee room consensus, because there may or may not be consensus, and it's quite subjective. Your opinion is different to my opinion, and trying to pick out the current themes and making that generalisable and therefore useful to the rest of NHS is the challenge. And I've done a little bit of it, and I think there is method in it, but it's not without flaws and challenges to make sure that this is done as rigorously as possible so that other people can have faith in it.
Okay, so you mentioned different people's opinions might be different.
Yeah.
So you presumably, when you're going into hospitals to talk to staff or to patients indeed, you're going to talk to a sample of people. How do you go about choosing which people to talk to or which situations to observe?
So firstly, I need to familiarise myself with the local context and work out who is doing what in terms of organisationally. And then I have a sampling strategy where I want to make sure I talk to representatives of all of the major stakeholder groups.
Okay. Like?
Surgeons, anaesthetists, managers, nurses, allied health professionals, and so on. And then from there, I will snowball a little bit. So they will say, well, you know what, in our hospital, we have a group that is doing X, Y, or Z. You should talk to them.
Mm.
And that will have to be on a sort of ad hoc basis. I'll work out who is relevant and who is representative. It doesn't help on the whole to have too strong outliers. You want to have representatives of their stakeholder groups.
Okay, fantastic.
And then the trick is to keep going until you've heard pretty much the same opinion coming out a few times and you've got a real flavour for what's going on.
Okay. And you're going to go to different places.
Yeah.
What do you think ultimately the benefits of the research that you're going to do will be? What's the aspiration?
So to improve I think in the first instance, it'll be to improve the outputs of national clinical audits or quality improvement programs. Because I think one question is that perhaps data is not being used because it's not being delivered to hospitals in a useful manner.
Yeah.
And that might be the type of data, the timeliness of when it gets to them, how it's presented, how it's risk adjusted, how it's compared to other hospitals, etc., etc. Those kind of things. So that's, I think, the first modifiable thing that could be changed. Secondly, it may be that individual staff, clinicians, don't have the confidence in using this data, and that may be they don't trust the statistical approaches of quality improvement, or they think everything has to be randomised and controlled before it can be acted upon. And so there may be a piece of work, which I don't know who would take it up, but that would be looking at clinicians' training, understanding, motivation. And I think the third piece would be looking at how clinicians are interacting with their hospitals, i.e. the management type structure and the trust type structure, because it seems to me that it should be in the interest of the trust to be facilitating improvement, because at the very least it should increase quality, but it should probably make it more cost effective as well. And so those groups should be working together. So if my work could help highlight this as an area where managers and clinicians can work together more effectively, then I think that would be useful outcome.
Great, thank you.
Thank you.